Okay, good to go.
Okay, I'll go ahead and get us started. Good evening and welcome. My name is Dr. Tristan Amador, and I'm the program director for the BC MHA program. I'm delighted that so many have joined us this evening for our webinar on the patient experience. I'm joined by our moderator, Dr. Basel Tarab, and a panel of experts on the patient experience. Dr. Tarab is a physician and a healthcare administrator. He works at Winchester Hospital in Massachusetts as the director of the patient experience. I'm incredibly proud to share that Dr. Tarab is a faculty member in our BC MHA program and also alumni of our BC MHA program. Finally, Dr. Tarab conceptualized this webinar topic, recruited our expert panelists, and much, much more. Thank you for your vision and your hard work, Dr. Tarab. And I turn this panel discussion over to you with gratitude. Thank you.
Thank you. Thank you, Dr. Amador, for the kind introduction and for giving us the opportunity to speak about this important topic. Patient experience is a huge passion and interest of mine, and I'm hoping that today with this panel of experts, we will be able to discuss what does patient experience means, how is it practiced in the hospitals, and the way I thought about it when I started thinking about this webinar is, different hospitals have different systems have different structures, but I thought of Beth Israel Lehi Health as a good structure to discuss because it gives us a very good example in which it's a system that has some hospitals. So when we assembled this panel, we thought that we should bring somebody who could speak at the level of the system and then at the local hospital levels, and then within each hospital, we have some experts who could speak to the actual patient experience work that is happening on the ground, and also what does it mean to be on the receiving end of it, meaning, well, not necessarily receiving, because patients are the ones who will receive the patient experience or they enjoy it, but who execute it, who execute patient experience. And also we have an expert here on in which she will tell us on how we act when things go wrong. Without further ado, I'm going to introduce our wonderful panelists here. I'm going to start with Mr. Mathew Doyle, who is the Director of Patient Experience and Quality at BILH System. He works along with Caroline Morrocco, who is a Program Manager for Patient Experience at BILH. And also they are joined by Chelsea Mower, who is the Patient Advocacy and Patient Experience Manager at Beverly Hospital here in Massachusetts. And Tracy Nadolny Burton, who is one of the nurse managers at Winchester Hospital. And finally, Jillian Wilsloff, who is the patient advocate at Winchester Hospital. I'm going to dive right into the conversation. Again, thank you all for joining us tonight. Matt, I'll start with you, and maybe just to ask, to start the conversation by what does patient experience means to you? How would you define it, and what does it mean in general, and how do you measure it?
Wow, what a leading giant question to start with, Basel. Really appreciate it. No, thank you. At BILH, historically, patient experience has been really narrowly equated with customer service or patient satisfaction. We're really slowly trying to start the work around making it a more expansive and holistic view of patient experience by really prioritizing patient experience, staff well-being, and safety in general, with an aim to create impactful experiences for all of our patients and for our own staff. For myself, Caroline, and our other BILH patient experience colleagues, we've really begun the important work and the preliminary work aimed at shifting that narrative away from patient satisfaction really to a human experience, right? Really trying to move it towards that piece of it, and really making central of that experience safety. And human experience really isn't just about like being friendly or courteous to our patients, while that stuff's kind of does matter, and we're not going to say it doesn't, but it's really fundamentally about safety and how we deliver safe care to our patients, and how we keep patients, our staff safe from from in that environment as well. Research by organizations like Press Ganey consistently highlight that patients who perceive their care to be safe have higher overall perceptions of their healthcare experiences. And so by emphasizing safety and a comprehensive human experience, we improve more than just patient satisfaction scores, right? We really enhance our clinical outcomes, our staff morale, and organizational efficiencies. When we prioritize safety, we directly impact our patients' trust and confidence in us. We reduce harm, we enhance clinical quality, and equally significant, focusing on that holistic human experience, we positively influence our staff engagement, reduce burnout, and return our teams to their purpose, really, in what the work that they're doing, which is hard work. And hopefully by doing that, we're creating a healthier and more sustainable workplace. From an administrative perspective, from an administrator like myself, the implications of doing this work is really profound. Driving patient experience translates into substantial financial benefits from our pay for performance programs that we have throughout the federal government and with our private payers. It also really translates well into our reputational, how we're seen by other people, whether that's Leapfrog, CMS, Health Grades, US News, World Reports, whatever, there's lots of different reputational groups, and they all look at that patient experience. So therefore, as administrators like ourselves, our commitment to redefining that patient experience as a holistic human experience guided by safety is really crucial. Ultimately, this approach that we're going to have will ensure our patients and staff and our communities have a great elevated experience, and one that creates a well-positioned environment for us to continue to deliver healthcare into the future.
Wow, thank you, Matt. So you mentioned a few buzzwords like safety, human experience, financials, no margin, no mission. So thank you for bringing that. So we're going to get back to these, but maybe I'm going to move now to Caroline and ask her, Matt spoke about providing holistic approach, and focusing on the human experience, not necessarily only patient experience, but how do you do that on a system level? How do you make sure that you have strategies built for the different hospitals within the same system? If you could speak a little bit about that, please.
So at at BILH, we're still, pretty young health system. We're 6 or so years into our integration. So we're definitely still in the early stages of building truly, like a unified approach across what 14 hospitals and hundreds of ambulatory clinics. But one of the biggest levers I'd say that we're really trying to use is to take advantage of the expertise. A lot of these people that you're seeing here, we brought together a lot of the patient experience experts across our system to create what we're calling an advisory council. And in addition to them, it has some other relevant stakeholders as well. But to focus on what are our priorities, figure out what's important to our people, build infrastructure, and set up accountability. And as Matt had mentioned, one of our most influential frameworks that we've been using is the work of Dr. Tejal Gandhi and the national database that Press Ganey holds that conducted an assessment in 2024 demonstrating a very powerful link between these perceptions of safety and experience. And Press Ganey's study had showed that when both patients and employees perceive a high level of safety, to bring numbers to what Matt was describing, they're 2.5 to 3 times more likely to recommend our facilities and to actually be engaged as employees and stay with our organization. So that was a pretty big light bulb moment for us. It kind of pushed us to think more holistically and to reframe the patient experience, not just as this siloed, hospitality issue, but as something that's deeply intertwined with safety and with quality and equity and this overall human experience that Matt was describing. So we actually replicated that analysis using our own BILH system-wide data and found a similar correlation that just confirmed for us that safety truly is the center of this wheel. So being the connection between patient trust and employee engagement, it's kind of validated. It's been essential in helping us align different leaders, getting buy-in across different entity, and sharing this vision for experience. So we're no longer talking about experience in this isolated narrative. It's now, the outcome of this safe and connected and human centered, care environment. So taking this vision and making it actionable, we've started to develop a multi-year roadmap. We're trying to focus on themes like governance and education across all levels, from the front line all the way up through middle management and executive leadership, system executive leadership, really touching on everyone, thinking about operational improvement, and really just thinking in terms of like a true culture transformation. Again, not just these patient experience scores. And we've also launched a collaborative learning series, which for us in this context, it focuses on HCAP's driver performance, and we've partnered with Press Ganey to do some baseline system-wide assessments, to do some national benchmarking, and these efforts have started to build a foundation. As I mentioned, like, it's early, but we are trying to get some early momentum, early interest, early engagement to push this work forward and move away from that traditional kind of outdated mindset that it's just about these survey scores and patient satisfaction.
Absolutely. And so you mentioned a few things as well. You said satisfaction, you said engagement, you said experience, you mentioned also HCAPs. And just to be sure that our audience are familiar with all of that, maybe I could ask Chelsea if she could share her perspective as a patient experience manager. What does patient experience versus patient satisfaction versus patient engagement mean to you, Chelsea?
Thank you for that question, Basil. I think, Matt kind of alluded to it earlier. Patient satisfaction is somewhat archaic and surface level in that it's just the satisfaction. Did we really please the person and give great hospitality while they were here? Patient experience takes it a step further with really trying to understand the care, if they felt safe, if they felt that we were communicating with them while they were here, to not only understand what workup was being done, what diagnosis we found, but how to take care of themselves outside of the hospital. And then engagement is something we haven't really started to measure quite yet, but I think is really the future. It's how we partner with the patient and get them excited to take care of themselves, be their own caregiver, and what they do for themselves outside of the hospital in our community.
And Chelsea, from an operational perspective, can you give us a few examples of some of the patient experience initiatives that you have at Beverly Hospitals, and how are they working for you?
Yeah, so in the post-COVID environment, it's been pretty tough to engage staff around wanting to improve the patient experience. It has kind of a negative connotation because I think when you approach staff with a patient experience initiative, they take it as, I'm not doing good enough care and something's wrong with it. So we've really tried to partner with staff and convince them that this isn't a critique of your care. This is a slight improvement of it based on, best practice. They're always going to align with you when you bring up evidence-based practice, because that's what they do when they give care. So we really partnered with our staff last year around quiet at night, really trying to make sure that staff just didn't accept the fact that hospitals are not quiet places. Outside of the hospital with everyday people, all we say about, being healthy is getting a good night's sleep. So why can't we give that to our patients? So once we really convinced our staff of the why and got their buy-in on that, we had a task force that was full of frontline staff, nursing assistants, nurses, night nurse supervisors, along with facilities and environmental staff. We needed buy-in from everyone who stepped onto the floor past 8 p.m. and made sure that they were taking stock of what were the noises, what changes do we have an impact over, rather than just coming in with, here are the scores and here's how you need to change it. I don't know if anyone has been watching The Pit on HBO Max, but when the administrator walked into the emergency department and had that conversation with the chief right there saying, your scores aren't good enough and you need to do better, I was actually very upset by that. That is not how you talk about patient experience. You really want your staff to partner with you on it.
Thank you, Chelsea. Maybe this is actually a good opportunity to turn to Tracy to maybe educate us a little bit on how to keep the clinical staff engaged with patient experience. And Tracy, as a nurse manager, how do you convince your staff, or do you bring the concept of patient experience to them while they are super busy in the clinical day-to-day work?
So, I'm very lucky over here in our corner of the world at Winchester to have introduced my staff to Maslow's hierarchy of needs. So when we sit and we huddle once, twice, three times a day, we talk a lot about meeting the patient's needs, making the patient feel special, making the patient feel safe. There are a few things that we do here, such as provider RN rounding. The patient feels very cared for when a nurse walks in with the provider and they have a conversation, and it becomes now a meeting, a healthcare team meeting, and everybody feels really confident and safe and like they're being cared for, and they are being cared for. Another thing we do here is present rounding. So there's 1 hour that the RNs round on all their patients, and on the other hour, all of our CNAs round on the patients. The patients are constantly being seen. We also do leadership rounding, which, we go into the patient's room and we go in with Basel and sometimes Jillian, and we go into the room and we ask the patient, how can we improve on our visit? With me, I find that if I walk into that room and I know that that patient's clinical picture is A, B, and C, I make sure that they know that I know that, because that also makes them feel cared for. Because if one person can know everybody on the floor, they must be special. I feel like a lot of what everybody is saying is safety and security is the main picture. That's what we really want to provide here, is safe, empathetic care. And then we're going to have happy patients who feel like they're really being cared for, mind, body, and soul. And we can get them up that ladder of Maslow. That's how we do things here.
Wonderful. So you mentioned the happy patients, but not every patient is happy, and we try our best, I think, to keep patients happy. But sometimes they are unhappy, and when they are unhappy, that's a problem, because that means they might lack compliance with the treatment. They might have a not super great relationship with the providers, and they might want to voice some concerns. So when they do that, they have to file a grievance or a complaint. And that's when Jillian comes, and when they call the patient advocacy department, or is also known as patient relations in some of the hospitals or organizations. So Jillian, can you tell us a little bit about the patient and complaining grievances process in a hospital? What does it look like? And what does your day-to-day job look like?
So when we go through the patient grievance process, a lot of the time my intake is either by person or in phone. Sometimes we will receive comments through HCAP surveys, and we'll proactively, look into concerns or make sure there's, no needs that aren't being met while they're in the outpatient setting. But when I get phone calls or I get letters that are in, I honestly first try to completely remove my clinical brain. I was a staff nurse before I took this job, a CNA while I was in school. So it is an ongoing process, and sometimes it is difficult, but I do my very best, just the first read through or the first conversation, to completely remove my clinical brain and to try and look at this with a fresh set of eyes. And I remind myself that, whoever I'm talking to, whatever letter I'm reading, whatever room I'm walking into, compartmentalizing or just grouping people in by diagnosis or issue is not going to do me any good, because I will only ever talk to this exact person once, right? There are no two people that are alike, so I have to treat each situation as its own. I look for, honestly, their deficits. I listen to their concerns or I read their concerns. I I differentiate between communication or more subjective concerns versus quality of care or objective concerns. So what I mean by that is if we get complaints or grievances and the main issue is communication with the provider, maybe their bedside manner wasn't what they preferred, or the teaching wasn't done in, a way that they were receptive to. Those things we resolve in a completely different way than we resolve the quality of care. Honestly, the more complex issues are the quality of care. In those instances, I will, either reach out to the patient if I need more information, or I go through and I take everything that they're saying in their words, and then I use my clinical brain then and I translate this into a way that all of our internal parties are going to understand. So, for example, if a patient had a negative intensive care stay and they felt like they were discharged too soon and they had an adverse outcome, in my brain, my clinical brain, and I know what my doctors are going to look at or what my executives are going to look at, or lab values they're going to look at, were there social determinants of health met? Did they have a safe discharge plan? But for these people, what they're thinking is, did you see me? Did you send me home early? Did you make sure I had what I needed? When I go through consultations and when I, consult either providers or, other caregivers, different departments, nurse managers, I try to be very specific in the things that I need, and whether that be, who interacted with the patient, what treatments did you do? Did you hear of any complaints? Was there anything that gave you an indication that they were unhappy? Honestly, the more information I can get from people, the better. But I try to be very specific in the things that I'm requesting, because I understand that, just the grievance process or just patient complaints can be very, very broad.
Absolutely. And, Jen and I usually have conversation about this, which is, usually the truth lies in the middle, right? It's a lot of like perspectives, the patient and Jillian said that the patient comes with a certain perspective. Um, and it's a very stressful situation. Nobody wants to be in a hospital. Nobody wants to receive care. Well, everybody, when they are sick, they want to receive care, but nobody wants to be in that situation. And when things go wrong, they have their own perspectives. And um, Jillian, how do you balance those perspectives with the facts that we have? Like, so how do you navigate that? And again, I just say this. I've heard it so many times that, when people speak to me, they say, we cannot do Jillian's job. She has the most difficult job in the whole hospital. So just, want to appreciate all the great work that you do. It's not easy that what you do. So can you tell us, how do you convey this message to patients?
Yeah. So first, I thank you. Honestly, I feel very lucky that I get to spend my days that people feel safe enough to call me, and they feel safe enough to trust someone that they've never met before to tell what could potentially be their absolute worst experience of their entire lives. And, the fact that somebody's able to open up that much to me, having, no previous relationship with me, I think it's genuinely an honor. When we have these situations, like you said, where the perspective and the facts don't always line up, I do my best to be as transparent with them as I can. And even during the intake process, I'm continuously navigating, what learning style works best for them. How do they best communicate? Do we have somebody that's more of an auditory learner? Do they do better with comparisons? Is there a language barrier? Is there a caretaker that's heavily involved where I should be having a group conversation? I make sure to align those things beforehand. And when we get to a place where the perspective and the facts do not line up, I do my very best to keep their perspective in full light when I'm explaining the facts. So if from their perspective, we'll use the early discharge example. If they think that they were sent home too early and all of our facts and all of my objective findings and all of my interviews are saying that we sent them home appropriately, I will tell them, our outcome is saying that you were sent home appropriately, but I take it a step further and I explain, here is why. I hear what you're thinking, or I'm hearing what you're telling me. I'm honoring your experience, and then I'm going to meet you and I'm going to tell you the gaps that I found during the review process. And I have found, well, no investigative process, no blueprint for a conversation is going to be 100%. Even if the outcome is not what patients want, they value being, like everybody said, feeling seen, feeling heard, and feeling like that their situation or their personal beliefs or whatever is important enough to be at the forefront of this. So if I'm explaining, hey, this didn't turn out the way you want, but your labs were appropriate. We did X, Y, and Z treatments on you. We got consults for you. We made sure that you had a safe ride home. We made sure that your house was okay, that you could get up the stairs, that you had outpatient appointments set up. And I think the more I paint that picture for them, that we are not only thinking of them just in that moment of time, but we thought about them 2, 3, 4, 5, 6 weeks down the road. I think that gives patients a peace of mind that we don't just see them as a number. They aren't just on a carousel of, patients that are coming in and out the door, that we see them as a person, not just a number, and that we did think about them from the time they walk in the door until the time they leave and beyond.
Wonderful, thank you. So maybe I'm going to turn it back again to Tracy, just to keep things practical. Jillian received a complaint or a grievance from a patient that they felt things did not go well. How do you take this information to your staff, if you could let us know, and to tell them or to follow up? What's your follow-up process? What do you do, and how do you bring that to the staff who is really doing their best to care clinically in a very sound way to the patient? How do you manage the situation?
Well, I mean, let's start by saying that every patient's perception is their reality. So it's very difficult to, step in the ring with somebody's perception. Jillian always very kindly calls us and tells us what the situation is. And what I do first is I review the chart. After I review the chart, I go and I find my key players, my staff, the CAs, the nurses, and we talk to them. If the patient is still present and there has been a complaint that's gone in, I've probably gone to see that patient at least once or twice already. So I have a good picture of what's happening. Once we get to that place where all the information has been gathered, and I obviously try to do a lot of service recovery at that point with the patient if they're still present. If not, I will call them at home. But I always check with Jillian to see if that's the right course of action in this particular case. So then I reach back out to Jillian and we have a conversation about next steps.
Wonderful. So you have addressed the complaint, and now, Chelsea, you are in a different hospital, but you also manage the Department of Patient Advocacy at your hospital. You collect data for the complaints and grievances, and you have a database. What do you do with this data? And how do you drive a change with it, knowing that this is very sensitive data because it's about, situation that went not in the right way, let's say?
Yes, so first off, we're very fortunate to have a database that tracks all of it. So it's not just one and done with our patient voice. We have told patients when handling complaints that it's not just this one-time response. We do track these issues, and they do find some reassurance in that. So I really try to stay on top of it every 2 to 3 months, checking for any trends that we're seeing and be not really ahead of it because these events have already happened, but approach certain area leaders just to keep them abreast to what we're seeing. We're seeing some complaints go up in the emergency department about, the wait time to be seen. Patients are saying they would like to get some updates. Can we fill in that gap anyway? And then every year or so, we do report it up to the state through the Board of Registration of Medicine annual report, but we also share it amongst our leaders at our performance improvement and patient safety committees and our board of trustees, so that all of hospital leadership is attuned to what our patients are saying and what matters most to them. And we actually do have a really great system set up. I don't know if we can give a plug to RL Datrix and our system analyst, Donna Wheeler, she has set it up so that we get readmission alerts to our emails, myself and our 2 patient relations specialists. If a patient who has provided us with some feedback that is in our database registers at our hospital, we get an email alert to say, this patient is now in your hospital. So we have opportunities to do service recovery after the fact, to give a heads up to the nurse manager, oh, this person had a complaint about call light response the last time they were here. And we can be proactive and try to prevent an issue from happening again.
Wonderful. So this is now the database for the negative data, but we also have database for the positive data. And Caroline, maybe you can speak a little bit to us about this data and how you, because one of the great things that I love receiving from you is dashboards usually. So if you could share with us, how do you prioritize what you put in these dashboards? And also, a few people here mentioned HCAPS, but I'm not sure if all of our audience know what that means. Can you please share what HCAPS is? And then if you could speak about sharing data with the whole system.
So HCAPS is this set of questions, just in layman's terms, that patients are answering. It's a standard set of questions, and reimbursement. There's reimbursement that's built around these specific questions. And to Chelsea's point, like, we are so lucky to have data from different data sources. I think that's one of the biggest things to focus on. Like, data should always be our guide. It's how we identify where to focus to understand what's really going on. It's how we measure whether we're making improvements or the other way. Unfortunately, it's in certain times, and without the data, we're just left with anecdotes that are oftentimes like a one-offs that spiral into myths, like it happened one time and then it's our story of what happened. So for me, like, the data is not just important, it's absolutely foundational to what we do in patient experience, but also in any improvement work across the organization. So again, like, full transparency, BILH is young at a system level with data, like the depth of our dashboards at the system level. Chelsea mentioned, all the individual hospitals have their way of looking at data that pertains to them and their needs, which is excellent. And we're working at the system level with IT to kind of shape the tools that are both, user-friendly and useful at the local level. But I think in the meantime, like, what's most valuable, at least from my perspective and how I've always utilized data, is it's a mindset, having curiosity about the data. And it's not just looking at any one score or one report. It's stepping back and asking, like, what story is the data telling us, and what else do we need to see to better understand the full picture? So Matt and I specifically, again, at the system level, kind of overseeing the bird's eye view of everything, we've been focused on thinking about pulling data from these different data sources that extend beyond just the surveys. So Chelsea had mentioned RL, for example. We in addition to the patient experience results, we're looking at safety event reporting, we're looking at employee engagement, we're looking at culture of safety, we're looking at other, general quality and safety outcomes, and trying to figure out how these pieces relate to one another. And that's where we hope to continue uncovering some of the most important insights that we can get. It's a more holistic picture of what's happening. So, for example, if patient experience scores are low in one area, you might also see some signals in these other data sources that I mentioned, where maybe staff might report lower perceptions of psychological safety, or the safety reporting might be inconsistent. These other pieces, looking at them in conjunction and adjacent to one another, it's not just a survey issue anymore, it's a culture issue. So this kind of, integrative and layered approach, it just helps us tailor our efforts at both the micro and the macro level, where at the micro level, Chelsea can be able to drill down into any specific unit or team or clinic or practice and align interventions that can specifically address the challenges that team is facing. And then at the macro level, we can identify, these broader themes and like systemic breakdowns that are best addressed at the system level. So operationalizing experience, to me, it really starts with just asking the right questions about the data and not just reporting on it and using it to generate like a shared understanding to target your action. And that's how, we move away from just looking at numbers to creating meaning and then using the story that we learned from the data to actually make actionable change and see change in the way that we care for our patients and the way that patients perceive that we're caring for them.
Thank you, Caroline. So maybe now, Matt, I could go to you. So now we have this data, and again, we're gonna look at the story behind it, not necessarily just the numbers. Using this data, how do you keep patient experience on the radar of the big system, on the highest level of the system? And we know, it's the healthcare environment or atmosphere nowadays is very difficult. There's a lot of competing demands. There's financial restraints, and constraints. There is, patient expectations have, went higher. There is a really good advancement in the healthcare IT system, so people might want to invest in that. So how do you keep patient experience in front of these theaters and to ensure that we are really utilizing this data to the best advantage that we have?
Really, truth be told, Basel, it's pretty difficult to keep patient experience at the forefront of the leadership's teams. There's competing priorities are abound everywhere, every system, every hospital, every unit, everywhere. Competing priorities, and they really dilute the focus. And when resources get really tight, guess where the one area that tends to be deprioritized all the time? It's patient experience. But I think what we're really trying to learn is that if we want to really elevate that patient experience and we want to make it a really, again, go back to that human experience, we want to integrate it with not just patients, but our staff and our safety. We really have to be consistent with our how we communicate with our leadership teams and really connecting it to the things that they find important, right? If we want to keep it in front of at their focus level, we need to talk about how it impacts our finances, how it really affects our safety, how does it really improve our clinical quality, and how does it really improve our workforce well-being. Those are the things that they care about. So to keep it at their forefront, we need to keep that, keep talking about it in those ways, so that they understand that having this focus on human experience will impact those other things that they care about as well. Right now, again, we've done a lot of work around trying to reframe that patient experience into that, away from that soft initiative, but really talking about it as a core safety and performance strategy, right? We want human experience to be a safety strategy. We want it to be a performance strategy. Again, going back to what Caroline said about Tejal Gandhi, showing that data, showing them how it correlates so well with our patients' experience, how it's going to improve outcomes. We see consistently that our units that have high safety scores also have higher patient experience scores. They have less falls, they have less pressure injuries, they have better clinical outcomes all along. So really being able to correlate that data has been foundational for us to really kind of to keep that momentum going. And so again, we've seen that data does not. We had the same patterns as Press-Ganey has, right? And it has shown. So again, keeping that at the forefront of our teams and really.
And Matt, maybe can you just explain what Press-Ganey is to people?
Sorry, yeah, Press-Ganey is a vendor that administers our patient experience surveys. So when Caroline was talking about the HCAPS, that's a patient survey that is administered by Press-Ganey. It's a company that just does the administration of it and provides us back the data on what our patients are saying for us. They kind of are the collector of the patient voice, I guess is what I would say, in that as a way of kind of thinking about it. But again, I guess just really correlating that human experience and trying to keep it away from making it a siloed effort, but really talking about how it can be a force multiplier on these safety and quality and workforce initiatives really helps kind of drive the thinking and allowing the system to look at it as more of an important priority when we have all these competing demands.
And Matt, you mentioned a few examples of the connection between safety and patient experience, mentioning falls, mentioning bed sores, and all those are reportable events that we have to report to the regulators. Can you speak a little bit more to the connection between patient experience and finance?
Mhm. Yeah, sure, of
Connection between
course.
happiness and money. I mean, I'm happy when I have money, but
Yes, I would say that there's quite a number of the federal government's programs have again, at the end of the day, CMS, which is the Center for Medicare Services, and a lot of our private payers have really wanted to move away from fee-for-service models. They really want to not make it about how many X-rays you do and how many visits you do. They want to really start driving it away from that and looking at it from a quality perspective. So a lot of the payment programs are now, those payers are now saying, hey, we want you to be better, and we're willing to, force you to do that by, giving you these measures you need to meet. And if you meet them, we're going to give you some of the money back that we're going to hold. We're going to hold some of your money. And if you hit your quality goals and your safety goals and your patient experience goals, we'll give you some of that money back. And so a number of those programs, CMS, which is again that handles Medicare, has a very big impact around patient experience. It's in their what they call their value-based purchasing program, which that's it represents about a little less than 1% of our CMS funding. So for an organization like BILH, 1% of our CMS funding is literally probably $10 to $15 million easily. So that's just one program. We also have Blue Cross Blue Shield, which is another one of our payers. They have a very huge financial impact and stake in seeing us improve that quality and that patient experience. So a lot of these payers have really, again, driven the idea behind we want to see improvement in quality, we want to see improvement in safety, and we want to see improvement in patient experience. And we're going to force you to do it by taking away your money and hoping you can earn it back. And a lot of, unfortunately, right now, the state of patient experience across the country, it's a lot of people are suffering and we're not getting our money back, which is, again, no mission, no margin, no margin, no mission, rather. It's harder. It makes it harder. It makes it harder for us as an organization to make the capital improvements that we want to make. It makes it harder to make the staffing, to increase staffing and to do all these things that we want to do, which then just creates a cycle of getting it worse and worse and worse. So it's hard to break that cycle, but it's so necessary for us if we want to continue to deliver healthcare in the way that we want to over the next 3 to 5 years.
And Matt, you mentioned that everybody, like recently, I mean, especially we could say, in January, February, that's historically have been a low point for the whole nation when it comes to patient experience for several reasons, related to increased volume of patients, maybe reduced staffing around this time because both patients and staff get sick, and we have more patients to see, and it's more waiting time, so that is all reflected on patients. But would you consider this a normal variation in patient experience, and how do you react usually to it, or do you just brace yourself for it and make sure that you just pass the wave? What do you do in this normal variation, and how do you respond to the leaders when they say, "Hey, your patient experience has tanked in this month"? What do you do?
So that's a really wonderful question. One of the things we're really trying to drive is looking at our metrics and our data using statistical process control, really trying to look at whether or not the score variation from where we are is actually statistically significant or not. Does it meet 3 standard deviations above the mean? If it does, or below the mean. If it does, then your process is out of control and you need to have an immediate reaction to that, right? If it's not, it's normal variation. We're going to see variations in our scores. We cannot chase scores all the time. It does not work. And it only creates conflict. And like you're saying, it creates conflict, it creates stress for people feeling like they have to raise their experience scores. There are just going to be variations in patients' experience across an entire year. And we need to be communicating that to our leadership, saying, listen, expect that the numbers are going to bounce around a little bit, right? They're going to go up a little bit in the, in this time of year. They're going to go down a little bit in this time of year. There's going to be kind of bouncing around a little bit. What you want to see is that, again, when you're looking at your data across a period of time, is it somewhat in tight numbers, right? Like, are you seeing little variations? That's fine. But like when you see like these big bounces and spikes, that's also a signal, right? Like that you're probably not doing standard work across the board, right? Because if you're not having that standard work, you're not creating a consistent environment. And one of the things that these surveys ask is, for example, did your doctor communicate with you well? Okay. The responses are always, most of the time, some of the time. If it's not always, it doesn't count for what we're looking at it to be counting for. So it's really imperative around us to have like consistent standard work so that people are all doing it the same way all the time, so that when we ask a patient, did your doctor provide great communication with you, they say always versus sometimes or rarely or whatever, because those are not going to score for us. So that and so a lot of times we're trying to get people to be like, look, when we look at our scores, you're not far off. If you can get some of those people who say sometimes to always, then we're going to be in much better shape. So it's really, again, about reinforcing standard work and kind of really understanding where you are to try to drive that.
Yeah. So you bring, educating people, and that's this, a normal variation or not. So Caroline, maybe I could answer this question. And this webinar is mostly for the students who are a part of the program, and they are administrators and or emerging administrators and leaders. What do you think are the essential informations or skills that an administrative leader would need to excel in patient experience?
Man. It's a whole lot, let me tell you. Being adaptive right now, specifically right now, is so critical because things are changing so rapidly. And it's kind of just scary. Like, we're all consumers of the service that we provide as well. So having that perspective, remembering, our clinicians, this is their day to day. It's easy to become kind of desensitized to seeing the same thing and having the same conversations, but to the patient and the person who's in the bed or in your office or wherever, like, this is a scary time, and it might be the only time or the first time, or they're witnessing a loved one go through something scary. Like, it's very different, being on the opposite side and reminding ourselves of that and putting ourselves in that perspective and trying new things that, we don't need to do things the same all the time because that's how we've done it forever. Like, being creative, thinking outside the box when things do change. How do we adapt? How do we keep perspective and keep connection with the patient, even when things are really, really hard? I'm not a clinician. I don't pretend to know what it's like to have 6 patients who are all super ill, but I am a patient myself, and there's definitely still a way to like come back to purpose, come back to connection, and remembering just like what it feels like. So, roundabout way to say, like, try everything and be patient and have perspective, because again, like, we're consumers of the service that we're providing. So I think that is a grounding reminder and what sets healthcare apart specifically than some other industries.
Thank you. And Tracy, as a clinician, leader, and administrator, what do you think are the skills that helps you in your day-to-day function to excel in patient experience? Or what do you expect from your staff to have to be able to execute good patient experience initiatives?
So I agree with everything Caroline said. You're a consumer as well. I've been a patient, and every time I've been a patient, it absolutely elevates my practice. I remember how it felt to get amazing care, and I remember how it felt not to get such amazing care. When I sit with my staff, we talk about what did it feel like when you were a patient, and someone didn't really validate your every worry or didn't seem to care about your needs. We do a lot of discussion. I have a lot of engagement with my staff because I want to engage them to the point where when they walk into the room, every single patient is an individual. I think they do a really nice job with that here. And I think that the patients feel safe and they feel secure and they feel special. But I don't think you'll get that unless you engage your staff.
I see engagement. And maybe now I'll turn to you, Jillian. What do you expect from administrators when you send a complaint or a grievance to them,
Yeah.
and why?
So honestly, the three things that I expect, especially during difficult grievance processes, I need trust and I need autonomy and support. Now, that can look different case by case, but when I ask for things, and I'm very blessed that I get this in the environment I'm in, but I know that when I ask for things, and if I'm very direct, if I say, I would like a formal peer review for this because I want to make sure on behalf of this patient that this was handled correctly. I know that my leaders trust me and my expertise and the skills that I bring to the table, that I'm asking for a reason, that I'm not wasting resources, that I know what I'm doing. If I encounter difficult situations, whether that be an escalated patient or disgruntled family member or a case that whether it be grief or, a social determinants of health, whether it be, death or something else extreme. If it goes out of control, I need to know that I have support from those above me and around me. And also, too, knowing that I'm not the expert in everything. I know that I bring many skills to the table, but there is not one person that can do every job. So I need to know, and I know that I have it, that I have the skill sets of those around me, and that they won't hesitate to use those to help me, to back me up. And, sometimes, and I'm guilty of it, like everybody's been saying, we're consumers of we're consumers of the healthcare system. There have been times where, I've gotten an opinion from a provider and I ask for a second one. It's the same thing on this side. People have taken what I've said and they say, this is nothing against you, but can I have a second opinion? Or, can I talk to your director? Is there somebody above you I can go to? And I know I ask for this, but I also confidently know that not only are they going to back me up, that they're going to reiterate and just solidify to that patient that, Jillian did everything she could. And, we were consulted early on. All of your resources were utilized. And, just, and again, I can't stress this enough for, people, whether it be direct patient care or it be, at the administrative level, to trust those around you and to be able to lean on your support system, because again, no one can do everything. And whether that be grievance investigation or that be de-escalating a patient, conflict resolution, you need to be able to work cohesively and you need to be able to have trust in those around you.
Yeah. Thank you. So Chelsea, you manage the patient advocacy department in Beverly, and what is your expectations also from your peer administrators? So not necessarily only building support and trust, as Gillian said, but let's say you sent a grievance to a department manager. How would you like, or what's the optimal response that you want from them? And I'm really asking this question because, not everyone here on the call will be working in patient experience. A lot of them will be leading departments. What are the things that a department leader need to respond to you on a complaint or a grievance?
Well, first and foremost, we ask them to really read the patient concerns. When the patient takes the time to write out a letter or an email to us, we really appreciate that opportunity because we just take that letter and send it right off in our database to this administrator or leader. And we want them to really read the patient voice, understand what their perspective was, and then try to speak to every concern that they had. It can be tough when some of those letters are very long or very angry. And we're all human. And I can understand as a manager myself getting defensive of your staff. But when I see leaders really take that complaint or grievance and approach it with an open mind and very minimal bias, we get really amazing responses where we are able to respond back to the patient and have a positive outcome or kind of meet them in the middle.
I see. Thank you. So I'm looking at the time and we only have 6 minutes. So I will turn it to the questions. So please, for the audience, please type in your questions and we will be happy to answer it. I have a couple of questions already. So one of the questions is asking, can you give an example of the questions that are being asked on the surveys? So, I mean, Chelsea, you mentioned quietness at night. There's a question about that. Can you mention a few other questions in which they are being asked on the surveys?
Of course. So the big key drivers of our metric this year is rate hospital 0 to 10 on a scale from 0 being the worst hospital possible to 10 being the best hospital possible. How would you rate this hospital based on your experience? And as Matt said, we only get credit for that top box. So the percent of patients who answer 9 or 10 out of that large scale. And we're looking at our key drivers. So the questions or domains on the survey that influence that rate hospital rating are nurse and doctor communication. There's 3 questions that fall under those domains. It's about respect and courtesy, listening and explaining in a way you understand. And then also responsiveness to call light, requests for help, and getting assistance to the toilet. Because those questions are really rooted in quality and safety. The most likely time a patient's going to fall is when they need to get up and go to the bathroom. So it's, again, not just about satisfaction, but about care and safety.
See, thank you. So there's another question about the role of AI on promoting patient experience. So I'm looking at
Ooh, can I
Caroline
take
and
that
Matt
one?
to answer that. Oh, yeah,
Can I
there you
take
go.
that one? I would love to. So AI is really one of the things I think we're really trying to bring to the forefront in BILH Quality Office. We are really starting to utilize this in a way that we think is a significant game changer. We're using AI to evaluate comments and to help provide feedback to organizations around their patient experience comments. So we get a lot of comments back on these surveys, taking those comments, putting them together, and coming up with the themes on those so that we can act on those things. There's also just all of this qualitative data that we're starting to really start getting collection on. It comes from the surveys. It comes from complaints and grievances. It comes from doing our rounding with patients when we do nurse rounding or leader rounding. There's all these qualitative pieces of information that we cannot possibly digest all by ourselves. And so utilizing AI is the way in that we can do that that it provides us with data that's just amazing in such a short period of time. I recently did a little talk on that and how we can use AI just to look at the patient experience comment piece of it. We can also use AI in looking at staff engagement comments and trying to find comments, theories around what people find important to them in our colleague experience surveys. So AI is really helping a ton. It's also just helps us digest data a lot better too. Like, okay, we're looking at what's our key drivers for our 9-10 score, right? Press Ganey can give us that information, but they only do it once a year. We can do it a little bit more frequently now with AI. We can drop it in there. You don't have to have a statistician on site to be able to run a key driver report anymore. You can dump a bunch of data into AI as long as it's de-identified. Don't put in medical record numbers, then you'll be in big trouble. But it will get us it will get the same data back to us in a much shorter time, and it will allow us to make pivots and changes to what we're doing at a much rapider pace. Super excited about AI and quality and safety.
Thank you, Matt. So I can tell you that for patient complaints, actually, there is, and this has been actually there for a while, some healthcare systems, and I know I'm aware of one of them in the Middle East, actually in Israel, that uses AI to analyze patient charts to predict patient complaints and grievances, so they can act on it proactively and intercept it before even it happens. So we only have 1 minute remaining, and I already have like a few other questions, but unfortunately we don't have time for it. Before I close with this meeting, can maybe one or two of you give an advice to the students about patient experience, or say something to them about it? Why do they need to really care about it?
For
I think
me,
you spoke a lot about it, but please.
I think for me, the best advice that I could give anybody in any role in patient experience is no one likes conflict, but you will grow so much by not shying away from it. And that doesn't mean that you go into every interaction thinking that you're going to solve everybody's problem, but going into it looking to help the person that, resolve the conflict, but also build your conflict resolution skills, build your communication skills, learn how to better navigate people. And, I think that we had worked on this in a previous time, but like even your quick response times, like again, nobody likes conflicts, but you're going to encounter it. And I think the sooner you embrace it, the more confident you're going to be.
Thank you, Eugenia. Maybe somebody else could say something, and then we
I would
can
love to, I'd
close.
love to comment on this one. I
Please,
think
Tracy.
I think a lot of nurses and providers get out of school and they're very task oriented. And I think that helps them get through the day. But in that, I think that the patient experience and the patient safety is, put on the back burner. And a lot of that is nerves and, just trying to get the job done. The patient is the job. So when you come into a hospital and you're dealing with your patients or whatever setting you're in, just remember that it's all about the patient. No matter what you do is all about your patient. And your patient needs to leave there feeling cared for. So the task needs to get done, and I will give you that. But those skills that you develop and give that patient that feeling of belonging and that feeling of safety is everything. So just try not to forget that. And I'm with Jillian as far as, conflict resolution. Try to deal with things real time. Try to address the issues right away. It really gives a lot to the situation.
Thank you, Tracy, for sharing this statement. Well, we are at time. We're actually 2 minutes past the time. So I want to thank our panelists for sharing their expertise, leadership, and for all that you do to our patients, and for Dr. Amador and the BC staff, and Jonathan, thank you for helping with setting this meeting and for giving us the opportunity to speak about patient experience, and for you, our audience and students. And thank you so much for joining, and have a great night and have a great rest of the week.
Thank you,
Thanks for
Basel.
having us.
Thank you.
Thank you.
Appreciate
Thank
it.
you very much.
Bye.